Good evening. I am Dr. D. Silver. I'm a neurologist and a movement disorder specialist at Scripps Memorial Hospital in La Jolla, California. Now tonight we're going to discuss Parkinson's disease, and we're going to focus on deep brain stimulation. This is a surgical treatment procedure for Parkinson's disease that is non-ablative. It does not destroy the brain tissue as procedures did in the past. So our overview tonight on deep brain stimulation has these important categories. One, we're going to talk about what is deep brain stimulation. Then we're going to tell you where we put these electrodes and the IPGs, where the placement is. And we're going to talk some about the programming of the IPGs after the surgical procedure. And we're going to tell you how DBS really helps the patients with Parkinson's disease. We're going to discuss side effects, so we're fair and balanced, and we're going to talk about and show case examples. Now this is a picture or a cartoon of a person with two IPGs in the chest area. These are placed underneath the skin, and they have an electrode that runs from the IPG up underneath the skin behind the ear, and it connects to the wire that actually has the electrode that is planted inside the nucleus or in the basal ganglia area. We are doing mainly subthalamic nucleus stimulation. So we have these IPGs, and today we actually only have one, and they connect with a wire that goes to the electrode. It's important to understand that Parkinson's disease is a degeneration of the dopamine neurons in various parts of the brain in Parkinson's disease. But what we're going to talk about is putting electrodes in various areas that are very important in helping treat Parkinson's disease. We're going to talk about three areas. First of all, the subthalamic nucleus, which is a little almond-shaped area that's very small. And then we're going to talk about an area called the globus pallidus interna, and then the thalamus. And these are being pointed out to you on these slides. Deep brain stimulation is a stereotactic surgical procedure that uses an implanted electrode inside the brain connected to an implantable pulse generator that's under the skin in the chest. That's called an IPG. And that delivers an electrical current to a very specifically targeted nucleus in the brain. We will mainly be talking tonight about stimulating the subthalamic nucleus. Now, the DBS and its journey in a patient really has a sequence. So first important is that we have to have a patient selection that is appropriate and select a patient that will do well with the DBS surgical procedure. After that selection, we get an MRI, and then the day of the surgery, there is a frame that is placed upon the patient's head and bolted into little areas to hold it tight. And this is a stereotactic frame called the Lensell frame. It's then a stereotactic target detection takes place, and then we have microelectrode recordings, and later, after those are done, there is a IPG placement in the chest underneath the skin, and this is shown by this cartoon again. The IPGs here, these are the pulse generators. They're connected with a wire which goes up behind the ear, and that wire has a connection to a wire that is connected to the electrodes, which are deep inside the brain, and we're going to be talking about the subthalamic nucleus stimulation. Now, people always ask, what does the basal ganglia do? And this is a very interesting concept about a group of nuclei structures that are present that have neurons. And they really are very important in motor function. And what they do is actually they help execute movements, they integrate movements, they modulate the movements and various parts of the body, and they coordinate various activities of movement. So motor activity in those four areas are very important. But the basal ganglia also has something to do with affect, emotion, reward, and probably sensory function. Now, the DBS site is very important to select, and we're going to talk about 3 briefly, but we mainly at Scripps Memorial, Dr. Ken Ott is the neurosurgeon and I am the neurologist, and we really mainly do the subthalamic nucleus, the STN, and that is a site that is selected for the treatment of Parkinson's disease. Sometimes we'll consider using the globus pallidus interna, and that's used for Parkinson's, but also for dystonia. And then the ventral medial thalamic nucleus is done for essential tremor. Now again, this is a picture of these areas, pointing out again the subthalamic nucleus, the basal ganglia area where there is a globus pallidus interna, and the thalamus. Now, surgery for movement disorders really is a very important, newly improved technique. It's been done for many years, and in fact, the first place it was done was at Iowa by Dr. Myers in the 1940s, and I actually saw some of his cases. But what we do in this surgical important procedure is we put an electrode in, we get a stimulating program, and we follow these patients very carefully. There were 2 types of surgical therapy that have been done. Ablative, as I talked about, that was done maybe 10 years ago, and a lot of that procedures were done and accomplished, and many people still have that. But it was fraught with difficult side effects, mainly when it was done bilaterally. People would get swallowing difficulties, dysphagia, slurred speech or dysarthria, and they would get cognitive changes. We are not doing the ablative procedures much anymore. We're doing the stimulating procedures such as DBS. Now, the technique for DBS involves, importantly, these important aspects in order. First of all, the patient is selected, and then we get an MRI, usually the day before. A stereotactic frame, which I will show you, is placed on the patient's head the day of the procedure. Then there is imaging by a CAT scan. These images are superimposed, or what we call fused. The patient is taken to the operating room where, while they are awake, there is a very small burr hole placed, and then there is an electrical recording done in the subthalamic nucleus after there is electrodes placed in the subthalamic nucleus by guiding these electrodes via a stereotactic procedure and guiding system that allows for location of this important nucleus. And then later in this nucleus, we do microelectrode recordings. An IPG is then placed under the skin. Now, this is a picture of the frame, the stereotactic frame. It has many coordinates, and you can see there is a guiding instrument at the top which allows for a guiding of the electrode into the appropriate place determined by stereotactic measurements. Now, this is a picture of Dr. Ken Ott in the operating room at Scripps Memorial, and he is guiding this electrode down this device using the frame, the stereotactic frame, which allows this to have a constant fixed position. This next slide shows us a picture of the electrode in the subthalamic nucleus. The subthalamic nucleus is very important. It's about the size of a small almond. It measures 4 millimeters by 8 millimeters. And you can see the electrode is placed in that area. And the electrode has 4 recording sites, 0, 1, 2, and 3. The next slide shows us a very important picture of how we can record microelectrode recordings in this area. So the electrode is placed, and we have a recording device, and you can see the first recording shows that we're above the subthalamic nucleus, and we get a very different kind of recording, very brief bursts, and it looks entirely different. But when we're right in the subthalamic nucleus, it has a characteristic fast, rapid firing discharge that actually you can tell the difference from any others by just pure sound. And then below that is an entirely different type of recording. So what we have here is a technique of using DBS that involves getting the MRI, the next day putting a stereotactic frame on that is fixed, and then we go into the operating room, do a burr hole, put the electrode in the area in the selected nucleus, and with that we can have this exact location by the stereotactic procedures, and then we do microelectrode recordings. And the last thing, we put the IPG in under the chest area under the skin. Now, we oftentimes program the stimulator, the IPG, after the patient is out of the hospital for several days. And this is done in my office by myself, or sometimes by my study coordinator, who's very expertly trained in this, or the other doctors. And we have the opportunity to help the patient improve. The patient has to be cooperative and knowledgeable, and we really use 3 parameters. Their voltage or amplitude, we can change that. Sometimes we'll change the pulse width, and sometimes the rate or the frequency. Now, who is the ideal candidate for DBS? Well, here's some characteristic features. They're younger, usually less than 75. They've had a robust response to L-DOPA in their motor symptoms, and that is key. No cognitive impairment, no major neuropsychiatric symptoms such as hallucinations, delusions, no profound comorbidity, and the MRI has little or no white matter disease, and the patient generally should have the disease less than 16 years. They have to be responsive to L-DOPA. The patient really has to have had optimized pharmacological treatment, individualized and tailored. Now, what are the features or the clinical symptoms that patients will have with improvement with the surgical procedure called DBS? Well, most importantly, motor complications will be improved. Especially, they'll have reduced motor fluctuations, reduced endos failure, wearing off, and reduced dyskinesias. And I'll show you an example of the dyskinesias. They're involuntary movements. But also, activities of daily living, reduced off time, and increased on time will all be benefited. Now, who is not a candidate for DBS? What Parkinsonism patients are not candidates? Patients with rapid progression, early falling, postural instability, swallowing difficulty, speech difficulty, cognitive impairment, little or no response to L-DOPA. Patients really need to have good response to L-DOPA. Now, how do we measure our improvement or our success? Well, we monitor certain characteristic features. Number one, we monitor the patient's off time, and we have them come in when they're off medicines in the morning. And we have them note, and we do certain scoring techniques, such as a UPDRS score, such as motor scores and activities of daily living. We determine the reduced amount of off time the patients had from the time before the DBS and the time now. We determine increased on time. We determine reduced severity of the dyskinesia. And we also determine increase in on time without dyskinesia, because that's a better quality of life, less impairing. And we also determine the decrease in on time with dyskinesias. Now, briefly, there's been numbers of articles, about 14 I've reviewed, and I'm going to select out certain trials I think that tell us some very important data. Measurements that help us show and document that DBS in this subthalamic nucleus is very beneficial. So I've selected a number of trials and series, and they're going to talk about 5 important ways to measure. First of all, motor scores. Secondly, activities of daily living. How do they do in their activities of daily living and improve? Dyskinesias. Are the dyskinesias reduced or better controlled or less severe? And do they have reduced off time, meaning they have more on time? Are they better when they're on their medicines and better since the stimulator? And can they reduce the L-DOPA dose? So let's look at the very first 6-month trial compared to baseline. In these patients, after 6 months, motor scores were improved by 52%. Activities of daily living scores were improved by 44%. And there was an increase in on time without dyskinesias from 27%, or a quarter of the day, to 3/4 of the day, robust improvement. Decreased in on time with dyskinesias from 23% to 7%, and decrease in off time from 49% to 19%, and the L-DOPA dose could be reduced by about 1/3. Now, the 5-year report in 49 patients, giving you the same kind of concept. Motor scores improved by 54%. Activities of daily living improved by about 50%. Dyskinesia scores improved. The L-DOPA dose was significantly reduced. And with time, there was no evidence of tolerance, or these patients continued to respond to the DBS. Akinesia, speech difficulty, slowness, postural instability, only got worse as would be expected with the progression of the disease. And for the people who program, monopolar setting was the case in 90% of the cases. In another series, in 26 patients, motor scores improved by 64%, activity of daily living scores improved by 66%, dyskinesias improved by 86%, motor fluctuations were improved, and the L-DOPA dose again could be reduced. Another group of 33 patients, emphasizing this procedure that surgical works, motor scores improved by 38%, activities of daily living scores improved by 30%, and dyskinesias were reduced. Off time was reduced, and the L-DOPA dose could be reduced by 44%. Why is it important to reduce the L-DOPA? Because that may be giving some of the side effects. And again, 20 patients. Here we have motor scores improved by 48%. Activities of daily living scores, again, improved by almost 50%. The patient can better live with their activities of daily living, requiring less help, less caregiver help. Duration of dyskinesias were reduced, and the severity of these unbelievably writhing, impairing types of movements was reduced significantly by 100%. And again, in this group of patients, L-DOPA dose was reduced by 33%. Now, I've given you here a slide that may be a little hard to read, but it is a meta-analysis structured by Dr. Cannot, who showed that in comparing numerous series, there's a significant improvement in the percent change of motor scores. It's about all the same. They run about 50 to 60%. Also, the reduction in the dyskinesias was about the same, and they could reduce the L-DOPA dose by about the same, 30 to 50%. Now, comparing the globus pallidus interna bilateral DBS stimulation, we see there's improvement too, but it's not quite as robust probably, and there are probably a little bit more side effects. So we've compared a little bit here in these last two slides, subthalamic nuclear stimulation and globus pallidus interna stimulation, and at Scripps Memorial, Dr. Cannot and I do mainly deep brain stimulation in the subthalamic nucleus. Now, I should mention Dr. Barba at UCSD is also doing deep brain stimulation and does a very good job, just like we do at Scripps Memorial in La Jolla. Now, it's only fair to talk about the adverse effects of a surgical procedure. And whenever we use pharmacological agents or surgical procedures, we always use this triad called efficacy, tolerability, and safety. This procedure is safe, but it does have surgically related side effects. Infection, about 5%. Intracerebral bleed, about 3%. Fortunately, at Scripps, we have not had any of these, and we've changed the technique a little, so I think that's helping us. We don't put the electrode through the sulci, we do it through the gyrus, which has, I think, been a benefit. Confusion and disorientation can occur, but not very commonly. Seizures are rare, and some of the other side effects that can occur. But there are also hardware-related adverse effects, and what are they? Well, there's the electrode and the lead that is a problem at times. It can fracture, there can be migration, or it can malfunction. That occurs in about 5% of the cases. There can be a misplaced electrode. There can be an absolute not appropriate localization of the electrode, and that does happen, but not very common in our experience, probably less than 2% in our cases, since we've done well over 100. Dr. Ott's done well over 100 cases now. Extension wire replacement can occur, and sometimes the wire that occurs here in the neck can be fractured. And a pearl, I think, is that sometimes people who have Parkinson's and they have a significant amount of dystonia or dyskinesias of the neck, you have to use Botox to help reduce that. And of course the IPG can fail. There are adverse effects with the stimulation that can occur when the stimulator is on or when you're programming. It's paresthesias or numbness, slurred speech. Sometimes the patients will have a problem where they can't open their eyes. They try to open their eyes and they can't. That's called eyelid opening apraxia. They can have dizziness or they can have a paradoxical increase in dyskinesias. Also, facial contractures can occur, and oftentimes that's a localization when you're programming the patient or when the patient describes it that the electrode is not the one that's appropriately selected. Now, programming is very important to understand. It is the job of the movement disorder specialist or the MD or his assigned assistant who needs to have very good training and experience to do the programming, and that's programming of the IPG. The patient comes in the morning to the movement disorders office. Like in my practice, they come early in the morning off medication, and usually it takes an hour or two, sometimes longer. And the important aspect after you change the programming, which I'll describe in a minute, is that they can continually have improvement of that programming setting for maybe days or weeks. And it may take hours for that programming to actually take to the position or the clinical benefit it may have. So you program at 10, it may still be showing changes later in the afternoon. So programming, what do? We change the voltage on the IPG, and less frequently we change that pulse width or the frequency or the rate. We may need to change the stimulating electrode, and I showed you very nicely the slide that had the electrode 0, 1, 2, and 3 that would span over that subthalamic nucleus that's only 4 millimeters by 7 millimeters, and that electrode is within that subthalamic nucleus, and you can change the site where you are stimulating. Usually most of the electrodes is in a monopolar state with what we call the IPG being positive. We observe later that the patient may take the medicine, and we watch the patient after they've had the electrode or the programming changes. And then if there is dyskinesias, we may want to reduce the dose. So in motor disabilities that are not affected by DBS, here are 5 key features that really usually aren't so robustly benefited by DBS. 1 is postural instability, the falling. 2, freezing of the gait. 3 is speech deficits. If the patient has a speech problem or it's severely impaired, DBS is probably not going to help it. Cognitive impairments and neuropsychiatric aspects. Basically, what we need to do is to think about these patients, and very, very importantly, we want to be in a situation where we select the patient and get the patient operated on appropriately with a surgeon who's lots of experience, and then we're going to have programming. Now I'm going to show you a patient here that has the DBS off and then the DBS on. This is one of my patients that's had DBS, and he's going to take his own apparatus and he's going to turn off his IPG. And he can do that, and you'll notice that he didn't have much tremor before, but now in his right hand he's getting dramatic increase of the tremor because the IPG is off. The DBS is no longer desynchronizing the subthalamic nucleus. And this is an important documentation and demonstration of this tremor that occurs. Now he's going to take the apparatus and he's going to go ahead and turn his IPG on again. And you'll see he gets a dramatic improvement in the tremor. Now it takes just a few seconds, but that is an important response. So this documents the IPG working. Remember that the patient's IPG is on the opposite side that he'll have a benefit with the tremor. This is a patient that has severe dyskinesias, and this is documented by his head movements and his hand movements, and you can see the arm movement and the dyskinesias are so significant they make him lose his balance. Importantly, in this patient, after DBS, his dyskinesias almost disappeared. So in review, deep brain stimulation. What have we talked about tonight? First of all, what is DBS? It's a surgical procedure that is a stimulation type of procedure that will help the patient in their Parkinson's symptoms. We put the electrode in the deep brain in the subthalamic nucleus. We do this through a stereotactic procedure, and most importantly is later on, after the surgical procedure, we program the IPG. It significantly helps patients. Dramatic improvement in improving motor scores, reducing motor fluctuations, improving activities of daily living, having the patient on more than off, and importantly, also reducing the L-DOPA dose. The side effects we've talked about, they can be surgical and they can be hardware, but by and large, they really aren't that many. And we've shown some videos in patients where we've had an opportunity to document to you the benefit of this aspect of this important procedure. So tonight we've had a very fast-paced program on DBS in idiopathic Parkinson's disease. I hope it's been informative, I hope it's been enjoyable, and I hope you've stuck with us, and I hope it's been encouraging to the patients with Parkinson's disease or to the caregivers or the relatives. I am Dr. D. Silver, and thank you and good night. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glen W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin.